Good morning, everyone. I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I want to welcome you to our third Lunch and Learn of 2022. And you are in for a real treat today. We'll be discussing two different articles. And the first is an article that was produced with support from PCORI, which is supporting this work to identify a key list of primary care articles and to help disseminate them to the primary care community. I encourage all of you to turn on your videos and also to put your organization name after your name so that we get a sense of who's in the room. It's also wonderful that our first article, there are a number of authors, including a patient co-investigator. So we have both, we've got a number of folks on that article and patient co-investigator, which we think is really terrific. Let me turn this now over to Noah, who's going to provide some additional announcements and then introduce our co-chairs.
All right, thank you everyone for joining. I just had a few quick announcements about some other kind of activities happening at the PCC. So the first is related to our July webinar. So in May, PCC released a primary care and health equity report with the National Center for Primary Care at Morehouse School of Medicine. And we will be releasing that report during our July webinar. And would love to have you join that meeting. And I can put the registration link in the chat. Another update. So we've had some thought leadership that was just published in Health Affairs. And it was a piece called An Option for Medicare ACOs to Further Transform Care. And it was written by Ann Greiner, President and CEO of the PCC, Mai Pham, who previously served as Chief Innovation Officer at the Center for Medicare and Medicaid Services, and Cliff Goss, who's President and CEO of the National Association of Accountable Care Organizations. Yeah, we encourage you to check that piece out, and I will put that link in the chat as well. Okay, so moving now into our discussion, I'd like to introduce our two co-chairs who will be facilitating the discussion today. So we have Dr. Jack Westfall and Dr. Irene Donkwa-Mullen, and we're really excited to have them facilitating the discussion. So I think we can go ahead and get started on the first article.
Thank you, Noah. Jack Westfall here. It's very exciting to be here for this Lunch and Learn and a couple of great articles, both sort of the full spectrum across research. The first is really exciting evaluation of the Learning to Integrate Neighborhoods and Clinical Care Project. Findings from implementing a new lay role into primary care teams to address social determinants of health. There will be a couple of speakers here. Dr. Clarissa Hsu is a medical anthropologist working with Kaiser Permanente, doing research since 2001. Became an official member of the faculty in 2011. She conducts research using a holistic approach that unites the cultural, social, and political factors that shape health and healthcare. PCORI funded research follows an innovative model, including patient input at all steps in the research process. The LINK project, Learning to Integrate Neighborhoods and Clinical Care project, designed, piloted, and evaluated a new primary care role, connecting patients to community resources. This new community resource specialist role was spread throughout Kaiser Permanente with a robust evaluation and implementation. I'd also like to introduce right now her co-investigator, who is officially, quote, the patient co-investigator, Janice Tufte was born and raised in Seattle. She attended college in Washington, Minnesota, and California with a focus on sociology and special education. Tufte has a passion for connecting communities, organizations, and individuals to one another. She is an expert in taking learned best practices and information gained from one organization and sharing that information with others at diverse levels, patient to C-suite. She calls this practice of connecting the dots pollination. She has been a PCORI ambassador since 2014 and has attended their annual meetings and presented at the PCORI annual meeting. It's my pleasure to turn it over to Dr. Hsu and Janice Tufte to present evaluation of the Learning to Integrate Neighborhoods and Clinical Care Project, findings from implementing a new lay role into primary care teams to address social determinants of health.
Thank you so much. It's really an honor to be here today to talk about this project. And I just want to kind of make a couple of clarifications. We actually had 2 patient co-investigators who are both named on that paper. So I just wanted to make sure Michelle Robbins got her due as well. All right, so let's go to the next slide. So the LINK project had 3 major components. So it was a little different from your standard research project. It had a collaborative design piece where we brought patients together with staff. So we had 12 patients and 11 staff members who co-designed this new role. And at the time, I think now there's been a lot of recognition of the need to address social needs in clinical settings, but this was back in 2011, 2012, and it was really still a nascent area that there wasn't much going on. We have this collaborative design component, and then we piloted the collaboratively designed role. At the beginning, we were calling it a clinic community linkage role, but we ended up calling it the community resource specialist. So you'll hear me talk about the community resource specialist, or CRS. And that's what we called it. So we piloted that in 2 clinics. And then the third component was that we had this very robust evaluation. And this whole project was a collaboration between our delivery system and our research team. We really worked together in ways that were unprecedented, at least at our institution at that time. And I will say too that we started as group health, and then we were acquired by Kaiser and became Kaiser Permanente Washington. But the role was eventually spread to all of Kaiser Permanente Washington. All right, next slide. So there were, I wanted to emphasize the patient and community engagement strategies we used. So there were several layers of them. So as we've mentioned, we had patient co-investigators. There are 2 individuals who participated in all of our team meetings, or at least our all team meetings, and were there along the way to kind of help us think through all phases of the project, from the design, the data collection, and the analysis. Then we had this collaborative care design process, which I briefly described, where we brought 12 patients and 11 staff members from those pilot clinics together for a full week, where they actually went from nothing to having job descriptions, training plans, and all of the kind of base materials we needed to actually implement the role. We had community advisory panels that were composed of representatives from community organizations in each of the communities where the pilots took place. We also did patient surveys as part of the evaluation and did a lot of observation, and we did focus groups with patients who had experienced this new role. Next slide. So I want to just give you, this is a little glimpse of the kind of what resulted. The CRS, the community resource specialist, was what resulted. And this is a little summation of that role from a couple of people's perspectives.
Having the community resource specialist there allows us to actually bring the village into the clinic and leverage that village to make this patient much more likely to succeed in their own treatment plan.
Our clinic has really embraced the idea of having a community resource specialist that can meet with the patients and help them find those resources, as well as working with the team.
I'm of an age where my memory slips and you're supposed to start doing new things, and I want to learn to play bridge again. Ask her if she knew if the senior center had them, and she said she wasn't sure, but she would call. And she did, and she not only called, but she had them send her some literature, and she went through it and marked all the places.
It really is a different level of, when we talk about care for our patients, and that's the caring piece. And our community resource specialist is the face of our clinic out in the community. It shows that we as a clinic care about our community.
My wanting to play bridge, I need it, number one, for my memory, because you need to learn to do something, and so I've got to learn to do it again. And then the other thing is that she cares, you know.
Those kinds of things really empower people to live better lives and to be healthier, and then everyone benefits.
Perfect. So just a quick rundown. I'm not going to spend too much time here on qualifications. I think there are a couple of things I wanted to highlight. We didn't think they needed a college degree. We didn't think they needed prior healthcare experience. They did need to have experience and understanding and sensitivity to how socioeconomic, environmental, cultural, and other factors influence health. They needed to have computer literacy, and they needed to have good collaboration skills and strong communication skills. And as originally conceived, it was thought that the community resource specialist would do about 60% of their time coaching patients and referring them to resources, about 30% of their time out in the clinic, out in the community, developing relationships and getting information, and then about 10% of the time working directly with the care team to teach them about community resources. That kind of held true, but I think less time was spent in the community than ideal. It was hard to get people out of the clinic and into the community, even though that was planned. All right, next slide. So the evaluation data is all in the paper. I'm not going to go through that. I have limited time, so I really wanted to focus on big picture learnings. So the first set are around role implementation, how you integrate this kind of role into your clinic primary care setting. And so the one thing is really getting clear about the role and what's expected. And even when we thought we had role clarity, we had people who had different interests. So one of the pilot CRSs really loved health coaching. So she did a lot more of that. And the other was very efficient and very good at getting resources. So she did a lot more of that. So just really getting clear about roles, and we're continuing to have conversations about that. Another thing we learned is that any new role in the clinic, because people aren't used to it, and I'm actually really getting interested in like how how learning is embodied, not just cognitive. And so people have to see that new role. They have to be in the center of things. They have to be visible. There is a long ramp up time for anything new in a clinic, so that needs to be considered. The other thing we really learned is that screening tools, and I know there's a lot of controversy about screening for social needs and whether it's universal or not, but there's a real concern, especially if you have these kind of roles, that you're not getting equitable referral to people. The people who somehow connect with their providers are more likely, and are upfront with their providers, may be the ones more likely to get this service, whereas other people may need it. And providers can make assumptions about people because they may present in a very put together way, and that doesn't necessarily mean they don't have social needs. And the other thing is there really need to be whole systems changes to accommodate both the referrals to community resources, having these kind of roles, but also thinking about how the information gathered by these new types of roles is used, and what kind of advocacy is done on the part of the system to address some of these social needs, because there does eventually need to be a boundary between what a clinic does and what community organizations do, but there needs to be some really systems level thinking about that, and changes that will help address these issues. Next slide. So the community resource specialist was spread to all of the primary care clinics in Kaiser Permanente, Washington. They began hiring in fall of 2017. There's at any given time, there's about 25 to 30 CRSs in the clinics. Most of them are full-time, and they base their calculations on 1 CRS to 20,000 members. They cover 34 medical centers. They recently unionized, which is interesting. And this role brings up a lot of questions about care and care work, and making sure we don't, disempower care workers or expect them to be low wage. But they recently unionized, which is interesting, and they are under the mental health and wellness department at Kaiser. Some of the training they get after they are hired, or that they go through the state community health worker certification program. They also get training in motivational interviewing and trauma-informed care. And we're also, there was also a very robust implementation support and evaluation project done after the implementation of the CRS, which I was part of as well. At the time, this was pre-pandemic. At that time, they were seeing about 1,600 unique patients a month. They had over 3,000 encounters a month, and 68% of those encounters were on the phone. Now, of course, with the pandemic, that went way up, as did people's needs. And I didn't have a chance to go and get new information. Next slide. Some policy and practice kind of lessons learned are really the importance of the patient voice. Having those patients in the room really, I think, changed what we did and how we decided to implement the role, what it looked like, but also changed how the providers and staff who were in there really thought about what they were doing and what they did on a day-to-day basis. So I think, that was really important. And I think it was also important to leadership to understand how important this type of role was to patients. You really need to ensure local ownership. That's both at the delivery system level and at the clinic level. So again, we partnered really closely with them. They owned this role. We didn't hire the role through the research team. It was hired through the delivery system. I also can't discount the role of serendipity in this type of work. So I think people who've done policy work also know, I mean, this isn't policy, but it's similar, that you kind of have to wait around and things can be really rough. And then suddenly there's a moment where things open up and you have an opportunity and things fall into place, because we had a really rocky road at first. And I thought, well, this is not I don't even know how I'm going to do this, but we managed. And then in the end, we happened to be at a time where we were acquired by Kaiser. They were interested in really enhancing the patient experience. And so they adopted and spread this role. And I don't think they can take it away at this point, because it is a beloved role. You need a team-based care model to do this kind of role and have it be effective. So that's something to keep in mind. And also that there are new mechanisms for enhancing sustainability now, with the Z codes for social needs and new capitated systems that are being rolled out, payment systems. So value-based payment systems. So really encouraging people to go and look at those new mechanisms to help support this type of role. All right, I think that's my slides, and hopefully I didn't go too far over. I'm going to pass it off to Janice for her reaction.
Thank you all for having us here, and I just want to say it was an exceptional opportunity for both of us patient co-investigators to be on this project. We came from different backgrounds. We didn't know each other until we met at the initial meeting, and it was a wonderful opportunity to really learn about research. Both of us were health research naive. I just want to add that. So part of the research role, there was quite a bit of project management that we had to have assistance with, a program manager, right? So to understand some of the terminologies. And the community resource specialist role, as Clarissa had mentioned, it was originally I just want to back up. We read the proposal, the Patient-Centered Outcome Research Institute proposal, both of us had independently, and added insights, and all the way to writing, and like Clarissa had mentioned, evaluation that is still going on. So we're not involved at this point. But it was a true learning curve, and both of us were really, we both had worked with community. So both Michelle and I, we came from different backgrounds, but we both were very invested in, the betterment of opportunities for community. And so the community clinic liaison was how it was kind of written in the proposal. It ended up being the community resource specialist that I believe the design team that was half patients kind of came up with that name and determined what the role would be. And they determined where the community resource specialists would be placed, and parameters and what needs would be needed. And so it was very exciting. I just want to say, from an individual who was research naive, but both of us had been involved with governance at Group Health, that's now Kaiser. And it was very exciting to see as results or outcomes were brought in, where people were sharing their excitement about having this opportunity, as you saw in the video. I remember being at a conference, and somebody was talking about social determinants of health, and I went up to her afterwards and I said, and she was at Kaiser, Washington. I said, I was one of the patient co-investigators on the project for the CRS. And she goes, oh my goodness, we just love it. And she gave me a few examples of how they help. And all I've heard is positive, outcomes of what people have, what they've experienced with the CRS. Oh my gosh, sorry. And so it's wonderful to have that experience on there, and the CRSs are still helping today, and as Clarissa mentioned, it's scaling across the state, which is pretty exciting. And so I think the next step is, and I'm very glad to see it's actually being recognized nationally. I mean, this is one of the first webinars where, as a patient co-investigator, that I've been on nationally, but it's also been brought to research. The ACT Center, that is the Learning Health Systems at Kaiser Research Institute, has a whole page on this project, the LINK project, and the community resource specialist that I will put in the chat. So, and I just want to add, during COVID, that's all I was thinking about, is how so many individuals that had special needs during COVID, how to get food, how to, perhaps how to reach out, what transportation opportunities are there. The CRS has definitely filled that role. And because we had that in place in the primary care clinics, it was a fairly easy transition directly into virtual only. I suspect, I don't really know, but I think it was because we had the virtual opportunities. So I felt very good about the fact, and proud to have been a part of this, and that we were able to offer these services during COVID and beyond. Thank you.
Wow, thank you too. That was terrific. What a great project. What a great presentation. I have a couple of questions that are just sort of logistics questions. And then I have a question that's a little bit deeper that will take a little bit more time. But if you could just answer these first two questions that are sort of the logistics. What are the unique patient and encounter numbers per month per CRS?
I would have to go, and I don't know the latest, you saw the overall, so you could extrapolate to about 25 people per, do the math there, but I'd have to go get the latest metrics, and I don't have those right at hand, but yeah. So
and then what's the approximate salary level for the CRS?
They started, when we first piloted, they started at the lowest level MA salary. I think that they're with unionization and just the changes in economy, I think that they have probably their salary has gone up. So I would be guessing at this point, but I think they came in at $18 an hour, but that was several years ago. And then that I would imagine they're up in the low to mid $20 an hour at this point. But they are, kind of at the lower tier of the clinic scale. so to speak. So yeah.
Thank you.
Also,
so-
I just want to add, they receive benefits also. So, right, they do receive benefits. So it's a wonderful position in our area here in western part of the Washington state is very expensive to live at. So that's something.
So there's a question that queries sort of, while Kaiser and as an integrated and capitated health system may be best suited to incorporate this role financially, what insight or information can you share about reimbursement or otherwise covering the cost of adding this role?
Yeah, certainly if you have access to capitated payment systems or value-based payment systems, that really makes it better. And I know that CMS is experimenting with that, and that's maybe the kind of future for many clinics to do a value-based payment system. So those types of systems allow you more leeway to do this, but there's also now Z codes which allow you to bill for addressing social needs. So those are another area to explore. I'm not a payment expert, so I would say go to somebody who's a payment expert to kind of figure out how you would best use those and what the parameters are. But I do know that a lot of clinics are taking advantage of that. Also know that these roles are getting much more common in FQHCs because again, they have a little bit more of that capitated payment system. So, but they're seeing a lot of value there. And I think there was a question about kind of the value proposition and what this role can do. It can take work from people. It allows people to work at top of license. So if you have your providers doing a lot of community resource research, that's a pretty high paid person to be, and person who has skills that time could be used elsewhere doing that work. And even with social work at our organization, the social workers were pushed to top of license and are actually doing, counseling and intervention rather than doing the community resource work. So it really supports the whole team. So I think there's a real value proposition there as well. So I will stop there.
I'd like to add to that. That was something that was exciting during the project that, we were, first of all, looking at possible medical outcomes, but you really need a longer time frame really to, see that with the goal setting and what opportunities. But the social workers right off the bat some of them were able to work their licensure. So that was a big plus. And I want to add on Z codes just because it's primary care. Z codes have really expanded, and I also serve on the Gravity Project and the executive committee, and there's a number of new Z codes. Actually, we have 17 that are in process or, that are already developed, actually, social isolation. So a lot of clinics don't take advantage of those, and we have to be sure that they do get reimbursed for those Z codes, and it's something that should be done if isn't currently.
So can you talk a little bit about the oversight that the CRS have so they don't go beyond their scope of practice and a little bit about that? And then there's a second question that I think goes with that that talks about certification, whether they are certified community health workers or how are they different than certified community health workers?
So let me take the first one first, because I think that's more straightforward, which is that they do not have to be certified community health workers to get the job, but that part of their initial training is just to complete the state certification for community health workers. So they do have that state level certification. Then the other question was, can you remind me, Jack?
Oversight for ensuring they don't go beyond scope of practice.
So initially, well, they were hired by the clinic and supervised by the clinic operations manager, who was an RN. But we also had weekly meetings. And then we actually, they actually ended up transferring over to mental health and wellness. So they're overseen by social workers now. And they really help. And they had a centralized, and I think they still do, kind of support system, support person who really cultivated and orchestrated their training, who met with them weekly, who debriefed with them, who made sure that they were kind of within scope of practice. And that I've talked to a lot of community resource specialists, and they are very clear on the boundaries. Those are made very clear in their job description, and they all know, like, I don't intervene clinically here. You know, I give a resource, I bring in another team member to help. A lot of them work really hand in hand with there's a social worker in each clinic as well. So they work really closely with those social workers as well, and can ask them, you know, this person's asking for this, you know, it feels like out of scope, and can check in with them regularly.
Janice, do you have anything to add on that question?
No, but you know, I just want to say that I think what Clarissa is saying from a lay person, from my perspective, is, you know, being a patient co-investigator and involved with governance, that what was interesting is that what you find out within a health system, you know, if you have a couple clinics, it might be easier to make a determination. But when you have a full system, things happen, right? Champions might leave, you know, COVID happened, confounders, whatever you want to call them, do come on. And so there's a lot of, I guess, metamorphosis. I don't know how to, you know, it just move forward as needs are needed as well, right? So the community resource specialist, I just want to add this, that no matter if you're on the eastern part of Washington state, it's very different from the western part. And so the dynamics of what the needs are of the individuals really can come out. So you might talk to somebody on, and some of the community resource specialists might have 2 or 3 clinics. So they do, you know, they're part-time, it's different clinics. Some of the larger clinics, they might be full-time there the whole time. But I believe there's 26 or 28 clinics currently, and I'm not sure how many community resource specialists we have. But as Clarissa has noted, that, you know, I haven't, and I'm not, you know, if I had heard negatives about it, I would definitely share it. But I have only heard positives, and I do think it is something that could go forward into other clinics in the future. But it, you know, having Kaiser, that we had these many clinics across the state, was kind of beneficial, because it was centralized and we're integrated, you know, research. So everything, you know, embedded research, it was what I see, it was fairly easy. On what, you know, Clarissa said, you know, it is hard. There was a lot of work behind the scenes, but it might be easier to scale when you have, you know, more than one clinic, and you can share whatever, you know, the operational and the nuances within each other.
Thank you so much. We're going to move on to our next article, but I would ask both of you to look through the questions, because there were a bunch of questions that we couldn't get to. Some should be easy to answer, some should be more lengthy answers, but if you could look through those and put your answers into the chat, that would be terrific. If they're longer answers, you know, we can try to figure out another way to do that. But I'm going to turn it over now to Dr. Irene Dunkwa-Mullen, and we'll move on to the next article. Thank you two very much.
Thank you.
Yeah, great. Thank you. Great, fantastic paper discussion. I am just as excited about the second paper, and hope we will continue to have an engaging discussion. I'm thrilled to introduce our next speaker, who will discuss the next seminal article on preventing colorectal cancer or early diagnosis, which is BEST, a reanalysis of the U.S. Preventive Services Task Force Evidence Report. This is going to be by our speaker is Dr. Scott Strayer, and he is the Harris Mayo Chair and Professor in the Department of Family Medicine and Population Health at Virginia Commonwealth University. He received his medical degree and completed residency at VCU. Also has a master's in public health from St. Louis University, and began conducting research on smoking cessation and health behavior change in primary care settings. He has significant experience developing innovative approaches to promote behavior change in primary care settings. And he has developed several NIH-funded computer-assisted tools to enhance smoking cessation, decrease alcohol abuse and misuse, address poor diet, sedentary lifestyle, lots. We are really excited, terrific to have him here to present this paper. So I will turn it over to you, Dr. Strayer. Thank you.
Good morning, everybody, and thanks, Irene, for the kind and generous introduction, and to the Primary Care Collaborative for this invitation. It's such a joy to see a diverse and wide-ranging audience from across the country to address such an important thing, which is colon cancer and colon cancer deaths. It's still the third leading cause of death for both men and women in the United States, and it's very preventable if people get screened. So me, along with, I'm sorry I didn't have an acknowledgement here, but I definitely have to acknowledge my first author, Andy Schwartz, who is a private practice family doc up in Alaska, who does some wonderful epidemiological thinking, and then Jan Eberth, an epidemiologist who I worked with when I was at University of South Carolina. Could not have done this work at all without their help and really without their initiation of this work. So what we, if you can go to the next slide, what we wanted to look at was whether the mechanism of action for preventing colorectal cancer was actually finding the colon cancer before it happens. So as in getting a polyp taken out through a colonoscopy, a flex sig, or for that matter, if it's visualized with a colonography and then going in and getting it, or is early diagnosis, which is mostly what happens when you are looking for bleeding in the colon by looking at stool-based testing, which is what it's trying to determine. And we initially started this work by reanalyzing the United States Preventive Services Task Force meta-analysis, their evidence-based review, and we reanalyzed it due to a little bit of an epidemiological glitch in one of the studies, in that initially the study was enrolling folks that were a certain age, then they changed it, and they changed their screen to control ratios. So the authors later acknowledged that the combined results from that trial should be separated. And so that's what we did. We just separated the two trials and found, lo and behold, that flexible sigmoidoscopy is actually the only cancer screening test in 50-something years that has been shown, at least in randomized controlled trials, to decrease all-cause mortality, so death from any cause, which is a much more certain outcome than when you start looking at attributable death, okay? And so the results I'm going to talk about, I'm going to talk a little bit about those results and then how we performed the analyses to show that reduction in actual colorectal cancer itself, the incidence, actually leads to the reduction in death. So if you can go to the next slide, please. I think this is just some summaries of what I just said, so we can certainly go on to the next slide as well. And this is a little bit of an eye chart, and actually, can you back up from that box? Yeah, sorry. There we go. Sorry for the eye chart here, but what we're really looking at here are the patterns. So hopefully you can blow it up on your Zoom if you need to. But what we're looking at here are the meta-analysis results across the three outcomes. The first box, the top box shows deaths. The second box shows colorectal cancer incidence. And then the last box shows death attributable to colorectal cancer, okay? And in each of those boxes, the top half shows the results for the flex sig results or outcomes. And then the bottom half shows fecal occult blood testing results. And the highlight here and what drew our team to go to this regression and correlation analysis that I'm going to tell you about was that in the first two boxes, you can see in the top half that there's a very similar pattern of reduction in deaths in the top box for flexible sigmoidoscopy, and then also in colorectal cancer incidence. And that's what kind of made us scratch our heads and say, I wonder if that's really the mechanism. I wonder if we can do a correlation for that. And maybe at least make that argument that the mechanism is not necessarily early diagnosis, which is typically what is thought of as what might be happening with fecal occult blood testing, because it's kind of hard to detect a polyp via a stool-based test, looking for blood. But with a colonoscopy or a flex sig, they're right there, they're visible, And, obviously the FlexSig only does approximately a third of the colon, whereas the colonoscopy does the full colon. So you can skip to the full next slide. Whoever's advancing it, go through those and go through that one. There we go. Okay. So this is the correlation and linear regression that we did to try to answer that question that we had, that we saw with those forest plots that I just demonstrated to you. And so I'm going to walk through this slide in that on the box on the right side of the screen there, you'll see that we did a correlation between colorectal cancer incidence, which is on the x-axis of the graph, and between death, which is on the y-axis. And the correlation was high when you put both FlexSig and fecal occult together, and it was statistically significant. You can see that in that middle box on the right side there. Shift your eyes then to the straight line that goes through this X and Y axis. And the dark blue boxes in the lower left-hand corner show the correlation or the regression analysis for all of the fecal occult blood, for all the flexible sigmoidoscopy tests, randomized controlled trials. So each box is a trial. And as you can see, it almost has a straight line relationship showing a very, very prominent linear relationship, so that it's almost 1-to-1, that if you reduce the incidence by one case, you're going to reduce death by one case, is maybe the example on how you would look at that. And then even when you add in the lighter green or magenta boxes, sorry if anybody's colorblind here, but those are all kind of the last four boxes on the right half of the graph. There's a little bit less of a linear relationship, although it technically does still have a correlation, which is that box that I showed you on the very right. So if you can forward to the next slide, please. So essentially what this showed, well, first of all, the meta-analysis that we performed showed that FlexSig uniquely and consistently reduces death across all the randomized controlled trials that were included in our reanalysis of the United States Preventive Services Task Force evidence-based review meta-analysis. And then our regression analysis indicates that prevention of colorectal cancer, so actually getting the polyps out and preventing the colon cancer from ever occurring, is most likely the sole mechanism of action, potentially indicating that early diagnosis of colorectal cancer does not have an effect on all-cause mortality. And I think you can go to the next slide then at this point. So at this point, I'm looking forward to further discussion on this, but some of the key takeaways that we were thinking about after finding these results and publishing them and presenting them and talking with people. And so it's such a great opportunity to talk to policymakers and providers and people across the country about this. Right now, flexible sigmoidoscopy is such a small percentage, around probably 1 or 2% of screening for colon cancer. And it used to be a much higher percentage. And actually, family medicine and primary care was where the majority of that was happening. And so one of the thoughts is, do we need to be looking at reintroducing flexible sigmoidoscopy into those practices and into providers' wheelhouse toolboxes as they are training? The other thing that this, for me, is a key takeaway, and I think the USPSTF said the same thing, is that we need to continue to pursue confirmation that the newer stool-based tests actually do reduce mortality, especially all-cause mortality. And so randomized controlled trials are certainly called for to verify and confirm the observational data, which is a little bit inconsistent in some cases. So there is good evidence that all of these tests reduce colon cancer deaths and incidence, not so much for all-cause mortality. And so continuing to kind of look into that and generate the research to prove that, I think is very important. There's no head-to-head, or there's at this point no RCTs that are head-to-head that look at these outcomes directly. So it's very hard to say that colonoscopy is definitely better, even though that's what we do in our country, versus when you look around the world, most countries are not doing this. So that's just an important thing to think about in terms of where we spend our healthcare dollars. And at the end of the day, the best test really is the test that somebody's actually going to go and take. Some people are just extremely reluctant to, or not able to perform a colonoscopy. It can take up to a full day of preparation, including a very aggressive laxative that cleans out your colon so you can go in and be visualized. And then the next day, you're, kind of really not supposed to be driving or working or making executive decisions. So it's kind of 2 days loss of work to get that test versus FlexSig can be done in the office without sedation and mostly painless if you use water-based insufflation. And then the stool-based test, of course, take home and do it yourself at home. So those are some of the things that need to be looked at in terms of being able to really continue to decrease the mortality and morbidity that we see associated with cancer, colorectal cancer, which also has very high disparities as well in its morbidity and mortality. And with that, I'm going to stop and open up to questions and comments and insights on our findings.
Awesome. Terrific. Thank you so much, Dr. Strayer. There are a number of questions coming through the chat, which is awesome. And I'll just go through and start with the first one. And I think you may have touched on some of it.
Sure.
This is a question from Esther who is asking whether if you can discuss colonoscopies and Cologuard in comparison to FlexSig and FOBT.
Yeah, so essentially, like I said, all of the tests have been shown to decrease colorectal cancer incidence and colorectal cancer attributable deaths, okay? There are only approximately, I think it's 9 or 10 randomized controlled trials that have looked at applying these screening interventions into populations or into a cohort and actually doing it in a randomized controlled fashion. All of the other data is observational and a lot of times just based on test accuracy, okay? So if to get it FDA approved as a test and to become part of the USPSTF, essentially they had to rely on the observational data and test characteristics. So Cologuard is one of the newer tests on the block. And essentially what they've done is done tests to show how sensitive and specific it is for detecting colon cancers and for detecting adenomas. And it has pretty good characteristics that are somewhat comparable to the direct visualization, maybe a little less comparable, but have still been shown in observational trials to reduce the amount of deaths. And I was looking at the overall reduction in deaths. The variation is maybe between 20 to 24, so only about 4 deaths difference between the different tests. So, when you're screening 1,000 people. So it's a small number. And once again, kind of goes to the point of the best test is the one that people are going to get. So, based on all of the data that we have, colonoscopy probably does prevent the most colorectal cancer, but with a plus or minus number of deaths of around 4 per 1,000 screened. I hope that answers that question, but.
Yeah, yes, and I guess a follow-up in terms of, there's a follow-up question regarding risk, but can you touch on frequency, considering age, other risk factors?
Sure.
Certainly in the African American population and other, they're higher risk, and any thoughts about
Sure.
that?
Yeah, and we basically follow USPSTF recommendations on that, and also the gastroenterology groups and the American College of Physicians and the American Cancer Society are pretty much aligned at this point, recommending starting screening at age 45. That's actually a USPSTF B recommendation. Starting at age 50 is an A recommendation. So that's the thing that has changed just in the last few years, is to start screening early. This is for people without symptoms, no blood in the stool, no change in bowel habits, no abdominal GI changes essentially. And as long as you're just screening, starting at age 45 now is a B recommendation. There's moderate evidence for moderate benefit from doing that. where was I going with that? So that's kind of the general age recommendation. The key thing I wanted to highlight though is that if you're having symptoms, obviously, you need to be evaluated immediately, and it depends. If you're a 20-year-old who's having some intermittent blood in the stool, and on exam we can evaluate and find that somebody has a hemorrhoid or a fissure or something like that, we may not need to do a colonoscopy at that time. But if you're 40 or 50, I would, even if they did have a hemorrhoid or fissure, if it's before the screening age, I would probably go ahead and send them for an optical, a direct visualization test. The other thing is if there's a family history of colon cancer in a first-degree relative, usually the high-risk group is first-degree relative and age less than 60 at onset. Now, I sometimes get people come in and say, Dad got it at 65 and died, and I'm like, I don't know if I would want to take that chance, but the guidelines are based on age 60 or less in a first-degree relative. And then there's some rare but very deadly hereditary diseases that create tons of polyps, polyposis syndrome, Gardner's, and a few others that people can sometimes get cancer in their 20s, 30s, 40s, early 40s. And typically that's something we look for in the family history and family history pedigree. And those folks get screened at least 10 years before the onset of that cancer. So if dad or mom or brother got a colon cancer at age 30, you'd probably want to start screening that patient at age 20 because there's something else going on there besides just the usual polyp formation and sequence.
Yeah. And where does virtual colonoscopy fit into?
So virtual colonoscopy is one of the newer tests out there. It has pretty good performance characteristics. The one place where it tends to fall off a little bit is in detecting smaller polyps and has a little bit of a higher false positive rate there. So that's mainly the only difference, is that in order to do that test, you still do the full day prep essentially as if you were doing a colonoscopy. Go in, get the CT colonography, and if there's something that's a couple millimeters that they're not really sure of, guess what? You're going to go on and get the colonoscopy anyway. So it once again, it's not an indictment of the test, but just to realize that it might be a two-stage test, and that there's a little bit higher rate of needing to have that colonoscopy then if they can't kind of figure out what something what a small lesion is that they might find. And it does require being fully cleaned out, and also it's not widely available everywhere. That's the other thing, and maybe not widely reimbursed everywhere. Although I guess maybe it technically should be, because it still is part of the USPSTF recommendations.
Yeah, there's a question about the virtual colonoscopy, and the camera pill is used for some of it, and they take whether you describe that procedure.
Capsule endoscopy is a yet another alternative, right. And the performance of that has just not made it into a recommended test by USPSTF and by I think by all of the guidelines that I just mentioned. Just may not be it's still in development, I think, to some extent. There still has been some testing done with that. We've certainly looked at capsule endoscopy for upper esophageal and stomach stuff. And so it's something that is continuing to be worked on, but isn't yet currently widely available or recommended as an effective screening test.
Mm-hmm. So, I mean, we usually want to think about the policy angle or the practice. I mean, and I think you said it, FLEXIC is not routinely conducted for primary care colorectal cancer screening,
right,
despite, proven effectiveness and lower cost compared to full colonoscopy screening. And it almost got dropped due to, from recommendation due to lack of availability. So what can we do? What can practices do to increase access or utilization of FLEXIC? Or are there policies that would facilitate its use, or any thoughts about?
Yeah, I think, certainly from a policy standpoint, I mean, I guess the guideline recommendations still include it. So certainly it should be reimbursed and could be encouraged as an alternative. I see a couple of angles to this, particularly as a family doc. who not only does FlexSig and colonoscopies, but also I train primary care folks to perform endoscopy, including colonoscopy. So to me, it seems like there's an opportunity to maybe revive or reinvigorate the use of FlexSig in circumstances where maybe there isn't availability of colonoscopy or easy availability or access to colonoscopy, and where somebody may prefer direct visualization as a better test than doing a stool-based test. It just seems like it should have some sort of role or place, and that primary care could be an advocate for that, particularly in underserved areas and rural areas where you may not have a GI specialist. You may and you may have still some reluctance to screening via stool-based testing. That's one of the things we're seeing actually here in Virginia, and we have one of the 3 enduring colorectal cancer death hotspots in the country. There's a big one down in the Mississippi Delta, but we have a large hotspot that's been there for years in the southeastern part of the state and northeastern part of North Carolina. And when we've gone down and done needs assessment in some of these practices, they're like, we don't have enough people to do endoscopy, so that's why we can't screen. And it's kind of like, well, wait a minute, what? First of all, what about FlexSig and what about stool-based testing? And so part of it is trying to, maybe inform people, potentially need some training there as well. And they basically came to me looking to train more primary care endoscopists, which could be done as well. But with the shortage in primary care, I think trying to go in and do a technical skill like that and devote a lot of time to that may not be necessarily the best use of our deployment. But a FlexSig is certainly something that could be done fairly easy. It's a short procedure, can be done in the office, and can be made kind of part of practice again.
Yeah, absolutely. So I know we're out of time, and I would like to thank you for a terrific presentation and great discussion. And I will hand it over to Anne to wrap us up, or is it Noah who would give the closing remarks? Thank you so much.
All right, thank you so much to our speakers for a great presentation. I put the quick meeting evaluation in the chat, and I will send a follow-up email as well. If you could please fill out that evaluation. And then we have our last Lunch and Learn discussion for 2022. That's in October 25th from 11 to noon. So yeah, I will be sending more about that in the coming weeks. And Anne, any final words?
Thanks so much to the speakers and our co-chairs, and for all of you attending and all the wonderful engagement and questions. I think we're really building a delightful primary care community that is eager and appreciates the evidence that researchers are producing. So thank you so much for joining us.
Thank you so much.